Good afternoon, everybody. My name's Gayle Dichter. I'm with InterSystems. We're a Cambridge-based software company specializing in integration, interoperability, and smart data fabric solutions. Through our partners like Epic and 3M, we manage 1 billion health records worldwide. So I'm thrilled today to introduce a session called Coordination Required for Successful Identification of Issues, Implementation of Interventions, and Analysis of Projects, presented by Gayle Dichter, love her name, RPH, MBA, Senior Consultant at the Pharmacy Group, and lketa, Mezini, MD, MBA, Director of Operations Strategy, Primary Care, Neighborhood Health Plan of Rhode Island. Gayle's an innovative, caring, and pragmatic clinician who combines business acumen, strategic vision, and realistic solutions to optimize member care and improve outcomes while delivering ROI. Joined by Dr. lketa Mezini, whose innovative program provides home-based primary care to high-risk, homebound patients who are members of the Neighborhood Health Plan of Rhode Island. Please join me in welcoming Gayle and lketa.
Thank you, and good morning, everyone. Really excited to be here today. Let me start by saying that I am a pharmacist by training, and I've spent the last 30 years focused in the health plan area, most recently working in the last year or two with value-based organizations that are affiliated with Medicaid health plans. So it's a perspective I'm coming from that I think I want to make sure that you're aware of. So what we're going to do today is I'm going to take you through a process. We've seen a lot of processes through this morning and talk about some of the challenges of each facet of the process and some of the best practices. But then lketa here, who I've worked with and is a great colleague of mine, is going to take you through one project beginning to end, how it was developed and how it's run and how it was analyzed. So we're going to give you little bits of process and then take you through a whole design. I always start with the question why. Why are we here today? Why is this important? Why are you sitting here listening to me? So the first question, Himss, we're talking about data, and everyone always talks about identifying actionable data. For those of you who were in the speaker before us, he talked about having loads and loads of data and not being able to do anything with it. So our purpose is to come up with clinical programs that are going to affect change. So we want to identify data that is actionable. But is that action going to be for a clinical reason? Are we going to improve patient care? Is it a business reason? Are we going to reduce costs? Or is it both? If the issues are then resolved, so you need to lead with the end in mind. That's really important. If the issues are resolved, will it save money? And if it's going to save money, we talked, again, the last speaker said how difficult it was to do an ROI. You need to, before you're implementing a project, how are you going to assess it? Other areas that are, from a business point of view, important. In the health plan area, regulation is important. So are you going to improve compliance? Are you going to end up with better care, and how are you going to measure the better care? And finally, a passion of mine is, at the end of the day, is it the right thing to do? And for most of my examples, I'm going to give you some examples, and one is of a childhood obesity project. For NCQA accreditation, a health plan has to, on a yearly basis, put together a population health review that says what percentage of their population have certain diseases, what's going on, how it's treated, et cetera. So in actually working with Neighborhood and lketa, we saw that the number of kids in Rhode Island that had childhood obesity was growing and growing and growing. So that's an issue. It's a data-driven issue. Did we need to do anything about it? At that point, we didn't know. So the first thing we said is, what are we doing about it? And we looked at our provider list, and we called our nutritionists and dietitians. I actually called a lot of them, and they all were taking care of maybe older teenagers or adults, but there were no programs out there for childhood obesity in Rhode Island at the time that we did this. There is now, by the way. So then the question was, all right, we wanted to take care of this population. It was important to us. Was a health plan the right person to develop the program? And the answer we got was definitively no. We wanted to develop a program for these kids that were inner city, that weren't eating right, that weren't exercising because they didn't have access. And so we brought different communities together, and we developed a pilot project where it was a summer camp for these children. We did not have obesity as the reason that they could join, because we didn't want them identified as, hey, I'm going to a fat camp. We just wanted them to have an enjoyable time. That was a mistake. The camp cost a lot of money on a per-person basis, and we evaluated the program by the kids, by their survey and how much they enjoyed and learned, their parents' perceptions, et cetera. But guess what? It wasn't enough to sustain this camp or grow this camp over time, because we didn't have a long-term metric that said how we were going to evaluate it. So these are some of the stumbling blocks that I like you to think about when you're developing your own projects in your own business. So when we talk about projects, we may be talking about projects at the global level. How do we treat diabetes? Or at the person level, and I'm going to spend some time on the person level because I'm, again, an advocate for care management. And the question is, in care management, how do you identify those single members that are actionable? When you look at clinical issues, you can look at, typically, when I started in the profession, everything was disease management. Disease management didn't work because they were looking at disease and not looking at individuals that had multiple chronic diseases. You may look at overutilization. In pharmacy, that's a big area where you look at people that are overutilizing drugs. You look at people that are experiencing high costs in the system. I underlined lack of coordination. And the reason I underlined lack of coordination, early in my managed care career, I worked for a company that was called Senior Whole Health. For those of you who've been in the business for a while in Massachusetts, you may remember what the SCOs were. They were senior care organizations. And they preceded the Medicare Advantage plans, especially the MAPDs in terms of Medicare. And we were well studied. There were 3 health plans, and they looked to say, what were we going to do? It was a care management-based plan, and through care management, the studies showed that we reduced entrance to nursing homes, and people that were in nursing homes were there for less time. And that's the reference on the bottom of the page. Also in Senior Whole Health, I learned how important, we talked about in the title of this, collaboration is. And you need to come from multiple perspectives to come up with some of the best solutions. We had care management rounds where we would look at members that we thought were challenging. We would have social workers, I was a pharmacist, we'd have our physicians, we'd have our nurse care managers, and don't forget behavioral health, because behavioral health is huge when you're looking at managing costs. We looked at one elderly gentleman who was he was a frequent flyer in the ER, and the nurse care manager just didn't know what to do. Social worker picked up her head and said, "You ever think that this guy's lonely? Does he have any friends? Is he in an adult daycare program where he could meet and be part of a community? Maybe if we get him Meals on Wheels, at least someone's knocking at his door and checking on him daily." We did all that. He stopped going to the emergency room. So the social worker's perspective in healthcare, and I think, lketa is going to spend a lot of time talking about social determinants of health, and not just the medical part, but the social part there. I have lots of items here, but for interest of time, the only other thing I want to talk about is HIV, because I get this question as a pharmacist all the time. I have my CFOs coming to me and saying, Gayle, the cost of HIV is going through the roof for drugs. What can you do about it? Well, guess what? Years ago, when we first started treating HIV, people were on multiple drugs. It was a hard regimen for people to stay on. They had lots of side effects. People often went off the drugs. And in recent history, we've got newer, better drugs, easier to take, less side effects, and more expensive. So what do I tell my CFOs? Guess what? This is good for the health of the community that we're servicing. Again, the right thing to do. Let's look at other ways to save money besides looking there, and let's take that as a win because we've got a healthier population. Okay, going from issue identification to what are the interventions that we're going to put together. So when you think about developing a program, it's really critical how long before you see the results. What's the probability of success of that program? The ROI up front, how are you going to evaluate it? What's the cost to implement the program? What's the cost to run that program? So we talked about big organizations and small organizations today, and a health plan can support some of the smaller physician practices. A lot of the Medicaid health plans are affiliated with value-based organizations now. They're called accountable care organizations or accountable entities in Rhode Island. So we use the analytics power in the health plan to look at data and suggest to our accountable entities what programs they could develop to better take care of their members. Alcohol use disorder was one that came up time and time again, not just for emergency room use, but these members were going into the ER for motor vehicle accidents. They were falling off ladders. They just all over had higher costs because of their alcohol use disorder. What happens typically is someone goes into an emergency room, they're treated, and they're discharged, but no one deals with the disorder. So one of our accountable entities that had a number, again, their numbers were high in this area, put together a program to identify these individuals when they were in the ER and to engage them into long-term care. Problem? It's not an easy solution to build, so your probability of success is not as high as you would like it to be, and the time to see results is longer. Was it a good program that they put together? Yes, but in order for that program to succeed, you needed to balance it with other programs that were going to have shorter-term wins. So again, looking at that. And I just have to, because again, we've talked about COVID, and I've got to talk about this because we did some really innovative things in healthcare during COVID. And one of the things when you talk about how does a practice deal with issues, pediatricians, what is a big part of a pediatrician's practice? It's giving immunizations. In COVID, the moms wouldn't bring their kids into the office for fear of them getting COVID. What did a number of pediatricians do? They had drive-through immunizations. And I think that is, again, when we think about programs and interventions, that was a great way to quickly turn around. So I talked a lot about the parameters and measuring what upfront constitutes success. And I'm going to show you an individual member profile, but I want you to think about doing a pre and a post on an individual is always difficult because you don't know what the course of their experience would have been without the intervention. In real life, you're not going to do a cohort test because you can't give one population a treatment and then not give it to another. We're in healthcare. One of the best ways to show improvement is to look at a metric that will show a change in a population. So if I put together a diabetes program, I could look at the population's hemoglobin A1C before and hemoglobin A1C after. So again, analysis is critical. There's a typo in the graph here in terms of the SDOH. Access to good food and housing positively impacts health, not negatively. Should have been poor access negatively. But again, the problem, and lketa will speak to it, is how do you show results? CMS just published, I'd say in the last year, a study looking at their value-based organizations saying that identifying social determinants of health issues in a person is not enough. We need to build more programs, and we need to make sure that once we build the programs, the people that need them have access and are comfortable to getting to them. So this is a tool, and I think tools are critical when you start talking about member identification. And someone said how difficult it is to look at how do you quickly look at a member or inpatient and identify everything that's going on with them? Well, guess what? For me, I love this tool because it does it. The yellow horizontal lines tell me that the patient was in the hospital then. The red horizontal lines tell me there was an ER visit. You have their med list by therapeutic category. So if we look at, I can't even read here, but anti-ulcer medications, you have famotidine, omeprazole, and pantoprazole. So you have duplication here. So you see that not only is there, and the bars next to the med show actually the fills in the day's supply. So you can visually, you don't have to figure out a compliance rate. You can visually see if there's gaps in the person filling the prescription. A dark bar means the prescription was written by someone other than the PCP. A light bar tells me it was written by the PCP. There is one, see the black, I can't tell, I think it's under BP, it's the furosemide. The black lines show that there was an overlap. They had double prescriptions filled at that time. So when you are purchasing tools, and everyone these days is looking at population health, how to identify members to interact on, you want something for a clinician that can quickly look and say, this is a problem patient, or this is not. And this is the same patient, by the way. I'm going to go back again. This is the patient. If you can look up in the corner, high-cost patient after the hospitalization. This is a real patient. There was intervention. There was care management. Resources were put in place. The PCP worked with that member. And then so following that, we reduced the medications. There are still some other providers there, but you see a much cleaner profile. So here's a picture of me in my dad's drugstore. I love Halloween, and I need to just close with that. And questions will follow lketa while she talks about Welcome Home.
Hello, everyone. My name is Mezini. I'm trained as family physician. I'm trained as a family physician, and I run a program at Neighborhood Health Plan of Rhode Island called Home Health. But today we're talking a little bit of a sample of the program that we started, and it is successful. So they called Welcome Home. It's a transition of care pilot program. We're addressing social determinants, done by community health workers. this is like what we're talking about, why is this? Medical underserved and low social economic status members, they face significant vulnerability and are at high risk of adverse events following hospital discharge. So the environmental, social, and economic factors, otherwise known as social determinants, needs to be assessed, identified, and intervened to stop the cascade of hospital readmission. As we know, hospital readmission are going up in the United States, and the cost of unplanned readmission is high. If we do a better discharge preparation and quality of care coordination, this will impact the patient care plan and would reduce the risk of unplanned 30 days readmission. Transition of care program, will help reduce the psychosocial barriers that prevent patients from being able to self-manage their condition outside the acute settings and help members effectively navigate through continuum of care. This transition of care program we called Welcome Home will be utilizing community health workers to identify social determinant gaps, help reduce preventable readmission in 30 days, also to engage with members before will be optimal, and after hospital discharge every week for 30 days. Where we focus mostly to assess the role of social determinant of health in contributing potentially preventable acute medical care service, identify barriers and gaps in care through social screening tools, focused on education, how to navigate the hospital discharge process, which is sometimes could be difficult and confusing, how to follow instruction in discharge paper, including meaningful of medical jargon and terminology, as well to review medication changes, and how to assess community resources. What we wanted to do with this program, we wanted to reduce the readmission rate less than 10% compared to Medicaid population in our state, and then build a strong relationship with 30% of the members. Everyone is talking about social determinant, but what is social determinant? They refer to non-medical factors that drive healthcare utilization and impact health outcomes. When you see in the iceberg, you see the visible and invisible. With invisible, we have clinical utilization, basic demographics, current enrollment, current engagement, but we don't see equity, access, income, stability, security, housing, disability, education, social stress, employment, environment, neighborhood, transportation, food, nutrition, family and makeup, multiple ways to reach, engagement preference, satisfaction with health plan. There are 2,500 more attributes and insights that define social determinant. But we focus mostly on the core subset of social determinants, like housing instability, social isolation, food insecurity, transportation need, utility needs, and interpersonal safety. Not all social determinants have the same impact in clinical aspect of it. For example, loneliness, lack of transportation, utility insecurity, and housing insecurity are all linked to lower diabetes medication adherence, a key element of clinical quality, and higher acute care utilization like increased ER utilization. Individuals reporting food insecurity, on the other hand, have high rates of emergency department visits, inpatient encounters, and avoidable hospitalization. This how we do transition of care population, what we did. We have every day, we have a daily inpatient census file. We have 7-day look back of member discharges. What is in there? It's demographic data, admission and discharge data, ER and inpatient utilization within the last 12 months, admission diagnosis, and discharge disposition should be home. What member we choose? I say member, but because in health plan they call member, but they are patients. So they are age 21 and above. There are Medicaid members who are discharged from hospital settings, medical underserved or low social economic status, high-risk adverse events following hospital discharge, and we chose the most chronic clinical conditions like congestive heart failure, coronary artery disease, hypertension, chronic obstructive pulmonary disease, asthma, diabetes. We excluded behavioral health, maternity, cancer, active cancer, and sickle cell. Why we use community health workers? Community health workers are the frontliners, are individuals from the community where they serve. They speak the same language, understand the needs, experience navigating the community and other systems. How are community health workers at neighborhood? They're all certified, and they are background, they're certified in diabetes and education, Spanish medical interpreter, nursing assistant, medical assistant background, phlebotomy. And they have other language, have access to resources, and they are trained in motivational interview. How they did it. As soon as the patient is discharged from the hospital, community health workers getting in touch with that member, presenting themselves, who they are, and what they want to do. The first one is encountered by phone, and then will be the visit at home. This will happen every week for 30 days. Provide in-home visits is so important because they create trust with a member when they're meeting in their environment. Also, they will take time to educate member on personal treatment. They'll have a possibility to connect with family members and caregivers. Will collaborate with provider, providing a holistic view on member needs. Also, these community health workers will have capability to offer all what neighborhood can do for this member, like care management, pharmacy, behavioral health, housing assistance, transportation, things that the patient read at the time. And after 30 days, if the patient still needs help, they will be addressed to the program primary care at home at neighborhood. As you see, the community health workers tool, the main of them is social determinant of health, where they do analysis, the admission by the transfer file, and they have to use the tools, accountable health communities, health-related social needs screening, additional screening, and motivational interview. But what do they mean by that? When we say accountable health community and health-related social needs screenings, these are by CDC. You'll find there are 26 questions developed there in depth that showing how they are done. We chose 5 of them based on housing stability, food insecurity, transportation problem, utility help needs, interpersonal safety. Additional screening. When you do that home visit with the members, they feel more comfortable, and then they can ask more questions, like who's completing the survey, need for interpreter, grade level, current living situation, and what is motivational interview. It's a little more detail where community health workers are trained to do that. For example, what do you know about your recent hospital admission? How do you feel about your health? Or how often do you have social support? Tell me why you only see them once per week, for example. In this page, you see that there are questions like you see Q3, Q4, these are coming from CDC. There are 26 questions the CDC provide. Academy of Family Physicians, they have short version and long version from 15 to 26, where you can find all of this. We picked those questions because these are more adapted to our population that we serve. And there mostly was food insecurity, family support, physical and mental health, but also what you see we wanted to see if they have combined of those needs, like food insecurity, housing instability, utility help needs. The questions are simple, straightforward, made to the patients. And then what you see in this, you see the data that 76% of the population that we did, there had the word physical activity absent. They didn't have. I wanted to mention that we started this pilot in October 2021 and finished December 2022. We had 139 members in this program. So that's why you see this data. It's based on 139 patients. 63% they had food insecurity. 47% have both food insecurity, housing instability, utility help needs. Following by family and community support missing there, and then education was less than 6th grade, and mental health was an issue too. You see, mostly by the population that we analyzes, in 139 members, 62% they were female, 38% they were male, and the age was 51, 60, 61, 70, mostly with their complexity of social determinant of health. Ethnicity was Caucasian, Black, Hispanic, also English, the language, some Spanish and other languages, and the race was again Caucasian, Black, and Hispanic. And then there was a percentage there that didn't provide what they were. This was another one in utilization that we wanted to talk, to see what's going on with our population. And we saw 81% they're using ER, and only 19% using urgent care. This was twofold. Why twofold? Because one, we want to see if our intervention will decrease ER utilization on one hand, and on the other hand, we wanted to make the aware of the member. If you have the medical needs, like to go to ER, please go to urgent care instead of ER. Cost less. Then, what we did from the results and analysis. Yes, we saw 139 members for one period. The analysis you have here is only for 50 members. Why is that? Because we did the analysis 6 months prior to the program, 6 months after to the program, and with 3 months lag of data because of claim. That's how it works in insurance. Then what did we see? We saw on the 50 members pre-program inpatient, we decreased that from 50 to 14. So we had decreased 72%. And we have the money from $758,000 to $420,000. We have saved $336. This is by cost avoidance. Also, we saw the decrease in emergency room from 120 to 94 by 22%. Based on this program, you say that addressing social determinant is worthy, and then this is now as business as usual in our process, so the program is successful. And I wanted to say that the zip code is more important than genetic code. So thank you so much for listening to our little program.
Hear me?
Yes.
Yes. Hi. Thank you very much, Dr. Mezini. I'm Dr. Tanya Hungstermeyer, and my team works extensively in a program called the Gravity Project, which is looking at technology enablers for, building a closed-loop referral system for addressing social determinants of health. And this is incredible data, and I hope you'll publish it in a journal or something, because I think that this kind of data is really important to drive the adoption of these kinds of strategies. And so I was wondering how you are connecting with the primary care providers who also manage the patients, because it's challenging as a plan provider to both engage the patients, get community-based organizations to deliver resources, and then get that information back to the care team that's on the ground. So I'd be interested to hear about that. And again, thank you.
It's a great point. We address those social determinants at the time. At the same time, when we figure out that the patient has that kind, we call primary care, and then let them know what's going on. And we follow through after. There are people that they are successful in the program, and they are being discharged, but after a while, they fall through the gaps, and they come back to the program. So we always in collaboration with PCP. That's the key, to keep the member out of these settings, out of ER, out of inpatient settings. And then they not only social determinant, they have other medical, but always keeping with PCP. This is our key of our program.
Thank you, Gayle and lketa, for a great presentation on successful project planning. So we have 20 minutes, and we'll be taking any more questions.
Yes, thank you for the presentation. You mentioned at the end that zip code is more important than genetic code. How do you compile the social determinants information? Do you use census data or some other source, and at what granularity?
developed at neighborhood the system, data system, where we have the data analysis. They collect that. They collect by the gender, race, all those factors that I mentioned, invisible factors, they're collected by our data analysts, and that's why we have our data reports. So that's how we compile and know it. We started, this is a new process that we started in January of this year.
All right, well, thank you.